Hi, my name is Nuala and I'm an anaesthetic SHO in Dublin. This is an audit on the perioperative management of diabetes mellitus in elective surgery against the 2026 guidelines published by the Association of Anaesthetists. Patients with diabetes are at an increased risk of perioperative complications, so getting glycemic management right matters for patient safety. We audited 17 patients over a 6-month period against these new guidelines. These guidelines set out recommendations for both HbA1c management and intraoperative glucose monitoring. In terms of the HbA1c management, they recommend measuring HbA1c levels within 3 months of surgery. And if that level is over 69 millimoles per mole or 8.5%, to consider postponement of surgery and specialist referral to an endocrinologist or a diabetes specialist. They also recommend that frequent capillary blood glucose checks should be done intraoperatively, at least hourly, especially for patients on a variable rate IV insulin infusion or in longer procedures. They also recommend keeping glucose within a target range, which within our centre is 6 to 12 millimoles per litre. In terms of our audit results, we found that every patient had an HbA1c measured within 3 months of surgery. So we are completely compliant with that guideline. In terms of escalating HbA1c to a specialist, 86% of our patients did not require that. 7% of those who did require a referral did not get one. In terms of glucose monitoring intraoperatively, 41% of our patients had their glucose checked intraoperatively and 59% did not. And bear in mind, these are all patients who have diabetes. Of those who did have their glucose checked intraoperatively, 86% of these patients were only checked once and 14% were checked hourly. When we looked at the median length of surgeries, we found that the median length was just under 2 hours at 112 minutes and the mean was 140 minutes. So these surgeries are long enough to require multiple glucose checks. Of those who were checked and not checked, we also want to see who was on insulin regularly. That would be at a more increased risk. So we found that of those who did not have their glucose checked intraoperatively, 30% of those patients were on regular insulin. So these patients would be at a high risk for complications. In conclusion, we know that we are completely compliant with HbA1c assessment, but our intraoperative monitoring of blood glucose is inconsistent. We endeavour to educate our theatre teams on intraoperative glucose monitoring and to re-audit in 6 months to see what improvements have been made and if any further action needs to be taken. Thank you.